Howdy, y'all. I'm Dr. Jeff Jarvis. Welcome to another protocol review module. Now, this one is actually probably still a PRM, but a procedure review module. So this one is about SGA insertion. Now, as y'all know, the SGA we use in this system is the wonderfully named AirQ3G. Yes, it took me a while to practice that. Now, in case you're wondering, there actually are other AirQ and AirQ3 products, but since this is the only SGA we're going to have in our system, let's just stick with AirQ, shall we? And if you don't mind, just send a couple of kind thoughts up into the ether for AirQ's poor marketing department. I mean, seriously, AirQ SP3G, they can do better. So guys, we're going to be using these SGAs as the only invasive airway in pediatric patients and the initial invasive airway in adult patients with cardiac arrest. Now, we can also use these as an option instead of intubation in adult patients who are not in cardiac arrest, who have respiratory failure, or they can't protect their own airway. I want to stress that again, as an option in those people. Now, finally, we can use it, as always, as a rescue in adults after a failed intubation attempt. Now, finding a contraindication for supraglottic airway insertion, I'll be honest, it's a bit tough. But in general, if the patient doesn't have a mouth into which to put the SGA, you might consider doing something else. Also, patients with a laryngectomy and who are trached and the top part no longer communicates with the bottom part, you can probably put one in, but it's not going to allow you to ventilate. So don't do it in that. And that's really about it. You can use these in just about everybody. Now, as with any invasive airway, we absolutely positively must confirm correct placement with good four-phase waveform entitled CO2. Or if we initially had a good waveform and then we lose it during the rest of the call, you got to remove it and do it with something else. So make sure you have good four-phase waveform. Now, we have several options for how we get the supraglottic in place. RSA with both ketamine and rocuronium, that's an option if you feel like you need it. Now, unlike with intubation, where you have to do whole hog or no hog full meal deal, with supraglottic insertion, you don't have to use both drugs if you don't think your patient needs them. Ketamine only, you bet, that's allowed, may be perfectly reasonable. If you feel like your patient is completely comatose, as I say, a GCS of 2, that's not a thing, by the way, a GCS of 2, and they have no gag reflex, well, then you can place the device with no drugs, again, if you feel that's in the best interest of your patient and the situation you find yourself in. Although it isn't required like it is with intubation, I and your patients would greatly appreciate it if you could get the SATs up to 94 or above before inserting the airway. Again, if you can. Remember, the supraglottic is there for those situations where you can't nail the physiology for intubation. Can't get the SATs up for 3 minutes, can't get the blood pressure up. Now, sizing of these AirQs, it's based on ideal body weight. And in adults, we're going to determine that by your best guess at height. Keep in mind our stretchers are about 6 feet tall. If they hang off the end of the stretcher, they're probably bigger than 6 foot tall. So the protocol app and the protocol itself, they have this handy dandy sizing chart that you can use for quick reference. In general, most adult men and women will take a size 4. Really tall people, they hang off the edge of the stretcher, size 5. Shorter adults get a size 3. And by shorter adults, I mean people even shorter than me. If you place a tube and it seems to have an air leak around the cuff, pull it out, put in a bigger size. Now, the G in that long convoluted name means that they have gastric ports. There's one on either side. They both go to the same place. I don't know that you can actually use two. I don't think there's an advantage, but they have a big honking port. You can put up to an 18 French in these things, which is substantially bigger than we can put in with other supraglottic airways. Best practice, preload the airway with the gastric tube to the point it's almost but not quite sticking out of the bottom of the airway. After you got it placed, after you have good waveform, then you can advance that gastric tube further in. And then you secure the thing with a tube tamer. Now, insertion is really straightforward. You put a gob or two of lube on the back of the laryngeal mask, then you flip it over and rub it around with your finger on the edges of the top and the bottom. So you're getting the whole thing good and lubed up so it slides right in. Now, just like with intubation, we want to suction all of the crud out of the airway first. Even if there doesn't appear to be crud in the airway, suction anyway. Crud is kind of persnickety like this, and it is very effective at hiding. It lurks down in the airway where we can't find it. It hides from us and then surprises us at the least convenient time. Suction first. Now, the tip of these devices, as you can see, is a bit flexible. That helps it form a better seal, but it also makes it prone to having the tip fold over on itself and block the airway. Now, if that happens, it's all right. Just pull it back, let it unflop, put it back in. Now, to help avoid that unfortunate floppage, I have two tips. First, since you'll already have suction in hand, move it over to your left hand, turn it around where the suction port is generally making the same shape as the airway, and then use that left hand to hold the tongue and the jaw up and out. You're essentially making the same movement that you might make with direct laryngoscopy. You're just opening the airway up with the suction. Then you aim the tip of the device for the glottis, not the uvula. Aim it anteriorly, not posteriorly. In other words, don't go straight down and hit the back of the throat. Instead, enter the mouth at an angle, aiming for the glottic opening. Now, the SP in this horrible name means that the Culf self-propagates, self-pressurizes. I think about it as it self-inflates. Basically, when you bag, it diverts some air into the cuff. The cuff inflates with each breath, and then it deflates with each exhalation. Now, why do we care? Well, that increases protection against gastric insufflation when you bag. In other words, it forms more of a seal to keep the air going into the trachea and not in the stomach. That's good. Pukage, bad. It deflates as you're not exhaling, as the bag is reinflating, and that creates less pressure on the oral pharyngeal structures when that pressure isn't needed. Well, that's pretty much it for insertion, for indications, contraindications, and for this video. Guys, as always, thank you for watching. Thank you for everything each and every one of you do every day to care for our community. Take care, y'all.